Ladies and gentlemen, thank you for joining Best of New Jersey Readmission Reduction Successes Interact Program. Your host for today, Tina Bunks, will now begin.
Thank you. Good morning and welcome to today's webinar. We are pleased that everyone was able to join us for this Best of New Jersey Readmission Reduction Successes Interact Program webinar. Healthcare Quality Strategies and Healthcare Association of New Jersey are proud to support NJ Lane as part of the Advancing Excellence campaign. Today's facilitators include Loretta Keys, the Director of Quality Improvement and Clinical Services at Healthcare Association of New Jersey, and Janet Noth, a Quality Improvement Specialist at HQSI. And we will also hear from a variety of providers and about their journeys toward adopting and implementing the Interact Quality Improvement Program. Next slide, please. This will be the last of our webinars on the Interact program. If you missed any of the prior sessions or wish to review any of the topics again, we invite you to visit the HQSI website to view the recording materials. Please see the chat box for the webpage address. Next slide, please. Before we begin the webinar, I would like to review some housekeeping items and make a few announcements. First, I hope that you've been able to download the materials before the webinar. However, if you did not get a chance to do so, you may download them by going back to qualitynet.webex.com. You can follow the instructions as listed in the WebEx reminder email sent to all registrants. We will have a question and answer session following the presentation. We encourage you to use the chat feature to submit questions during the presentation. Please be sure to submit your chat submissions to all participants. Your postings will be addressed and answered during the question and answer portion of this webinar. Please note that your phone lines have been muted. After the presentation, the operator will open the lines to take your questions and comments. We also ask that you please respond to the evaluation questions that will be available at the end of the presentation. It helps us to improve and plan for future events. Finally, this webinar will be recorded, and we will make the recording available to you after the presentation along with materials. Next slide, please. As noted, today's presenters represent a wide variety of healthcare providers that have implemented the Interact program. You will hear about their experiences as well as their successes, barriers, and how they overcame those barriers. We are proud to have the following providers here with us today. Robert Wood Johnson University Hospital located in New Brunswick, Victoria Manor, a nursing facility of the Genesis Healthcare System located in Cape May, Chelsea Senior Living with 12 assisted living communities throughout the state of New Jersey, and the final presenter from Inglemoor Rehabilitation and Care Center located in Livingston. Next slide, please. Now I would like to introduce our first speaker, Teresa D. Peralta. She is the Transitional Care Coordinator at Robert Wood Johnson University Hospital. In addition to her role at Robert Wood Johnson, she also attended the Interact Institute and has been active in supporting the implementation of Interact. With that, I would like to turn the webinar over to Teresa.
Thank you very much, Dinah. Good morning, everybody. I'd like to thank HQSI for involving Robert Wood Johnson New Brunswick in this webinar, and I'm very happy to be the voice of the transitional care program of the hospital. Next slide, please. When we first started the program at Robert Wood, it actually went as far back as August of 2011 in designing the program. We started enrolling patients January of 2012. You may have heard that our model is quite unique in that we are engaged with the Robert Wood Johnson VNA, using visiting nurses as our transition RMs, and we have been committed from the onset to be engaged with our post-acute care or subacute facilities and nursing homes. Having started the enrollment and having gotten a few patients in the program, we then invited the post-acute care facilities in May 2012 for a dinner meeting. Our program is grant funded at this point, and we are able to enroll patients only within the 30-mile radius of the hospital. Therefore, we invited the post-acute care facilities within the 30-mile radius. The goal of that night was to outline our program, what the workflow is, how we hope to see patients, who are we going to enroll in the program. More importantly, we wanted to set the expectations for the post-acute care facilities that actually either send us patients or who we send our patients to. We wanted to communicate what help Robert Wood Johnson can also provide to these facilities, as we believe that it has to be a two-way street. Us helping them prevent unnecessary readmissions, and the facilities also preventing unnecessary readmissions to the hospital. Right from the outset, Tier 1 of East Pacific was forward in wanting to partner with us. They were the charter partner because they have created what they call a care navigator model, who is a nurse practitioner designed to follow the patient who is rebounding back from their facility to the hospital, and will follow that patient in their facility. Their model facility was East Brunswick. Today, we also have other preferred partners. Bridgeway Care Center was also forward in talking to the hospital and wanting to establish a relationship. We also now have preferred partner with Aristocare as well as with Genesis. Now, we have preferred partners because in any program, there will always be early adopters. Whether that's a facility or a hospital or an organization that sees the vision. And we also believe that whenever you start something new, it's always great to start with the early adopters or those who already share the same goals and beliefs. And we did want to have a successful program. It is a grant, and therefore our funds were finite, our times were finite, as well as our resources. We want to partner with those who are willing to walk the road with us. And that might be one of the learnings that we should keep in mind. How did we engage them in terms of interact? So part of my role is to actually be the one as the resource person for the program to find out what is it that we could use in our program. And Interact, of course, stood out as the most adopted program to prevent readmission for subacute and nursing homes. It is a great program, however, there was a lack of a national study. And lucky for our program, it was just about that time that they formulated the national study. So my role at that time was to actually I contacted Interact, and I recommended two of our preferred partners to participate in the national study, telling Interact that these are engaged partners of the hospital and that we will have ongoing relationship with them. As Diana said, I attended the Interact training program because I wanted to be able to offer that as a trainer to our partners' facilities. We offered to help the subacute facilities with the Interact implementation, meaning including training in the planning stage and in the follow-up. We also ended up having follow-up meetings with facilities, and this continues to this day. And we have invited them to our transitional care meetings, which occur every other week at the hospital. Next slide, please. We're talking about the community collaboration. As I said, our current active Interact partners are what you see on the slide, Tier 1 of East Brunswick, although they have many facilities. This is the facility closest to our hospital, Bridgeway Care Center for both their Hillsborough and Bridgewater facilities, Merrick Care Center, has been engaged with us. Regarding strategy, not have interact when we first worked with them. So the director of nursing was actually recommended to attend the institute in Florida, and she was going to be the trainer and the main implementer at their facility. Now, some of the other facilities have already dabbled or even implemented Interact. However, when I first started working with them, the question was, how is the implementation? How deep is the implementation? Is it truly implemented? And do you have outcomes? We are very careful about, digging deep into the programs that we align with, because we are very much into accountability. The same way that those current partners with us actually report outcomes. I'll illustrate to you later. We also provided a model for evaluation. We find that our role is to help guide our partners. In our meetings, monthly meetings, we routinely go over our readmission statistics because we would like these facilities to look at their statistics not 1 year down the line of their program, but to look at it on a monthly basis. We look at ours every 2 weeks. We always do a root cause analysis of everybody enrolled in our program that for some reason continues to get readmitted. And that's exactly what we want our facilities to do as well. We provide them a sample of how we do it, what we learn from it, and as well as the philosophy behind root cause analysis, which is not to put blame, but to find out what is it in the system that probably results to the breakdown. Or, on the other hand, it could also be that our best efforts may not necessarily be good enough for a certain segment of the population. What I mean by that is that, for example, we found in our root cause analysis and every 2 weeks analysis that some of our patients are not really candidates for teaching. Meaning, the real reason for their readmission is possibly because they just really need to be placed in a nursing home, or that they cannot afford their medication. Therefore, the last bullet, as you see, the workflow modification that we have instituted, not 1 year down the line, but as soon as we found that trend, was to refer those patients to a social worker within the VNA. Spare a resource, a precious resource of a registered nurse visiting that patient, instead sending the social worker whose intervention will be more meaningful. And that's exactly the model that we would like to show. We wanted to show our post-acute care facilities, that by constant and frequent analysis of the readmission cases, we could find trends, and that maybe changes can be made in a true continuous quality improvement strategy. Next slide, please. So, many lessons learned every 2 weeks, every month, right? But there are also barriers. There are realistic barriers, not necessarily. Maybe some things to consider. We do not, the program does not operate in a silo. As you can see there, we have things that we needed to consider in terms of legal and risk management requirements. For example, we wanted to do bedside delivery, and that is not, although that is adopted by many, it is not necessarily as easy, and we needed to look at those as the issues for risk management. We also needed to save, the forest of our foundation and give them the money. And so we needed to actually give them an update. The RWJ VNA who engage visit the patient's home, but we found that despite organized care and home care, they still rebound. And so we found that there is a great need to re-educate the visiting nurses. The nursing facilities, as I mentioned before, we need champions and early adopters. Now, for the other nursing facilities who are not yet preferred partners, we found that one of the reasons they are not engaged at this point is possibly because of a lack or not enough corporate quality strategy, or maybe it's really simply because they do not have the personnel, and we we are sensitive to that, and that there is really, truly a need to re-educate in terms of what the readmission problem truly is. Next slide, please. For the benefits for the hospital, for the hospital is that they will reduce our readmission rate, as you can see in the last slide. And for the facilities, one of our role is that with the partner facilities, we've been able to connect them with Jersey Health Connect through the New Jersey Relay. And that has really helped them in terms of being able to screen their patients even better. Robert Wood Johnson partly subsidizes the salaries of the nurse practitioner or the RN, who is the care navigator from the preferred facility. Next slide, please. What did we find from the Interact that's really helpful to us is the capabilities checklist. It tells us what the facility can do. I think it also tells the facility where they can improve and where they can improve alignment with certain specialists. Until you put it down, you don't know what it is that you can and cannot do. The triage map we found very helpful in educating the staff in the facility. In terms of the version of Interact that is used, our partner facilities use both, and in the process of refining as well. Next slide, please. The next following slides are meant to just show you what two facilities do. This first facility has started reporting every quarter to us. And what I want to show you here is not so much their results and what their goal, it's just that they have put it down on paper. And in the next slide, as you can see, these are some of the strategies that they have actually, or workflow modifications that they have implemented as a result of what they saw as the trend, like bringing in bedside delivery in their facility, and changing the role of the care navigator. They started with a nurse practitioner who ended up rounding in their facilities, and an RN became a care navigator. In the next couple of slides, I want to show you what one facility that implemented Interact is doing. I'm not here to show you what the results are, but just to show you that once you start trending, and this facility trends their nursing home, their assisted living, and their subacute care, it is only when you start showing this in this graph and in this line that you truly see the trend of all your facilities. And in the next slide, look at this. This is how they are now tracking their admissions up there. Because I would think that I thought that the readmissions would occur on the weekend. They're actually showing there's less readmission on the weekend and more occurring on a Monday. Is it because the Friday was waiting for the Monday to get intervened upon? But that's exactly what we want them to do. We would like them to start looking at this and looking at their process. But until you actually do it in an itemized manner as this, you don't know what you're doing, and you may actually be doing really well. Next slide, please. And in this case, these are the diagnosis, the trends in diagnosis. What's really interesting in this facility is that it's not really CHF-AMI pneumonia. Shortness of breath became one of their outstanding reasons. Now, of course, what is shortness of breath? Is that COPD or is that CHF? And that is exactly what we mean by taking case studies, going to root cause analysis, and determining your learning from there. They also have a high percentage of others, which needs to be defined probably better. And believe me, this is not unique to subacute. This happens in hospitals as well, where the diagnosis for which the patients are admitted is kind of vague. Or change of mental status, which is one of the most difficult things to filter through. The last couple of slides I have, next slide please, I think I've talked about this already. Root cause analysis, case studies, some of these are quality-based changes that we've been able to help the facilities implement. And in the last two slides are just results from Robert Wood Johnson. These are, maybe not quite the Interact results yet, but the partnership that we have with the post-acute care facilities is showing in the results, whether this is through just transitional care or because of the partnership we still need to tease it. And I thank you very much. I'll be very happy to take any calls later, or you can email me, and we'd be very happy to share more with you.
Thank you very much, Teresa. That was very valuable information, and I'm sure a lot of people will be able to move forward with this motivation. It's now my pleasure to introduce our presenters from Genesis Healthcare in Cape May County. We have Donna Mayer, is the Director of Nursing at Victoria Manor, and Denise Raymond is the Senior Admissions and Marketing Director from Genesis. Now I'll turn it over to Donna.
Thank you. I'm Donna Mayer. I am the Director at Victoria Manor in North Cape May, New Jersey. We are a 20-bed facility, long-term, with numerous skilled beds. Next slide, please. Denise is also here with me, but she'll speak a little later. When Genesis, the Interact tools were piloted in several centers prior to it going corporate-wide a couple years ago. The goal was to decrease the rehospitalizations out of the center. The key players responsible for the initiation of this in our center was the nurse practice educator and the DON. In our center, the DON assumed the responsibility of determining the root cause of why we had such a high rehospitalization rate. Once that was determined, we had to decide what tools we were going to use here at Victoria Manor to help decrease that rehospitalization. Genesis Corporation introduced us to the Interact tools, the SBAR and Stop and Watch. They also introduced us to the Interact website, which did provide us with much more valuable tools that we are also using. The tools that we use right now that we put into effect is the SBAR, the Stop and Watch, and the Care Pathways. Next slide, please. Next slide. The root cause analysis determined that one of the main reasons patients were being transferred to the hospital from long-term care facility was that the MDs had a lack of trust in the assessment of the nurses. This involved the nurses' assessment and the MD's lack of knowledge of our capabilities. The doctors were sending patients to the hospital for evaluations after one phone call, which usually sounded like, your patient doesn't look good. The MDs were not able to make accurate decisions regarding the care of the patient due to the lack of a comprehensive and accurate assessment provided to them by the nurses. So the goal was to educate. We educated the nurses on giving better assessments. We educated the MDs on the capabilities of our nurses and managing their patients in our facility. We educated our staff on the use of the Stop and Watch in an effort to catch these changes early. And we educated the our local ER staff on our capabilities and allowing us to give the best possible report to them during a transport. Next slide, please. We use the Care Pathways to educate our clinical staff. We use the Stop and Watch to educate our support staff, which was the aides. Also, we included dietary, housekeeping, activities, and therapy. The forms were easily accessible to the staff. We keep them at the nurses' station, blank forms, and also each department has some blank forms. We use the SBAR form to help train the nurses to better assess the problem. The nursing capabilities list were distributed by Denise, and she will explain that in a later slide. Next slide, please. The use of the Care Pathways gave the clinical team a consistent protocol to refer to. The Stop and Watch allowed our support support staff to become more involved since they do see the patients daily and do notice changes in them. The SBARs were used to track the patient's condition and the interventions that were used that worked or didn't work, which we continued to use the SBAR during reports from shift to shift until the problem was resolved. Denise will explain in a later slide about the goals and the process she used to get the word out. Next slide, please. The barriers. Change is sometimes challenged, especially if the staff does not understand the reason behind the change. This was a culture change for our nursing home because in the past, when a patient became ill, they were quickly sent out for treatment. So when we introduced the nurses to the SBAR, they were like, oh my God, because we worked on getting the clinical team on board and convincing them that this process will work. They needed to embrace the change. We started with the unit managers who, I was very lucky, did adapt very quickly to this. In turn, they worked with their staff nurses on the units to ensure that these SBARs were being used. When first looking at an SBAR, it does appear somewhat overwhelming, especially on a busy day when you have a lot of patients and they're sick, but the staff became more comfortable with them the more they used them, and their confidence and assessments improved. Next slide, please. The stop and watch tool is given to the unit managers once it's filled out by the support staff or to a supervisor on the odd shift. The forms are then reviewed by them and passed to the floor nurse, who then addresses the issue. If it is an actual change in condition, the floor nurse then initiates our nurse's note called the change of condition note, which continues for 72 hours. If it is not an actual change of condition, then we do monitor this change that someone noticed for 24 hours on report and in our general note. The unit managers actively monitor these forms, which are given to the DON when the issue is resolved. When there is an actual change in condition, the SBAR is started prior to calling the MD. The SBAR is used for report and whenever the doctor is called again for the same issue. It is documented on the back of the form. Therefore, we have a quick reference on what interventions we tried, what worked, what didn't work, and we can update the doctor as when we call them about this issue that this is what we did. It was a quick reference, and the nurses liked that. It gave them a lot of confidence. Next slide.
Hi, this is Denise. Since the goal of the tool, the Nursing Home Capabilities List, was to educate the emergency department that every transfer was not an admission, the first step that I did was I personally met with small groups in the emergency room department at our local hospital. I met with nurses, doctors, care management staff, including social workers and RN case managers, as well as nurses' aides and techs in the emergency room. I explained the capabilities list, gave them copies, explained what our center was able to do, and the goal behind utilizing it. I actually left with the emergency room department nurse manager the capabilities list in a clear plastic sleeve so they could keep it in a binder at the nurse's station. Donna and myself also met with the director of care management at the same hospital on a separate occasion, which was rolled out to the social workers and RN case managers so they were aware of what our capabilities were. I then delivered all the completed capabilities to local physicians' offices in person and explained to the staff there, whether it was the physician or a nurse in his office, the purpose behind utilizing it. And then we actually educated our own nurses and especially per diems and part-time nurses, as well as our medical director and attending physicians on the capabilities list and how they were to utilize it to reduce sending folks out. Next slide, please.
The unit managers are responsible to fill out a rehospitalization assessment when a patient gets sent to the hospital, so we can determine if that hospitalization was avoidable or not. Then at our QA meetings, a report is given on the previous month's rehospitalization. This process, with using the Interact tools, appears to be working for us. Our rehospitalization rate in 2011 was high as 31.3%. In May, we were down to 9.6%. It is still work in progress, but we are heading in the right direction with the use of the Interact tools. The other Interact tools that we use and we keep on the floor as a reference is the care pathways. We also have the lab test and diagnostic procedures and the signs and symptoms. They're all reference tools from Interact. In June, we had 8 SBARs filled out, and there was only 2 admits out of those 8 SBARs. So it's still work in progress. It's not perfect. We're still working with our clinical team, but I think the Interact tools really did help us to get a hold on this. Next slide.
The next slide just has our contact information if there is any questions or comments regarding our presentation. Thank you.
Thank you, Denise and Donna. Before we continue, we would like to get your input from on one of our polling questions. The question is, what barriers do you need to remove? If the operator could please bring up the first polling question, then our audience members can select. You have about 30 seconds to complete this poll, and then we'll take a look at what kind of answers you have, and I'll be curious to see what they are, and hopefully we'll hear some good tips from our presenters how you might be able to overcome some of them. Well, looks like the time is about counting down, and shortly we'll be seeing the results.
Just a few more seconds.
Okay, thank you. Technology is pretty amazing that you can tabulate these so quickly, so I'm still amazed. Here they are. You know what? I'm not sure. The operator, do you know if anything happened? We see that there were no answers on any of them.
That was really weird because people definitely answered.
Okay. You know what? In the interest of time, let's just move along, and we'll just say how wonderful we are. Nobody has any barriers, but obviously, if you do hear and learn about anything along the way, I hope you'll jot them down as ways to overcome your barriers. With that, I'm going to turn it over to Loretta, who's going to introduce our next speaker.
Good morning, all. It's my pleasure to introduce to you Elaine Jeffers, RN. She is Regional Director of Health Services for Chelsea Senior Living. Chelsea, as Donna said, has 12 assisted livings in New Jersey and others in New York and Pennsylvania. In her role, Elaine is responsible for the quality care of the residents living in those assisted livings. It's important to note that she's also the chairperson of the New Jersey Assisted Living Nurses Association. The ALNA, as it's called, collaborated with Dr. Joseph Oslander and the Interact team to develop forms for the assisted living. They are being piloted across the nation and in New Jersey as of this moment. I'm hoping that they will be ready for implementation in the early fall. It is important to note, though, that even though the forms are not yet sanctioned to be used, the stop and watch and the SBAR can definitely be accommodating to the purpose that they're intended. So, Elaine, good morning.
Good morning, Loretta.
I'm going to ask you several things because I know that you have been piloting parts of Interact program in your Chelsea facilities. How did you find out about the Interact Quality Improvement Program?
Well, fortunately, there have been many opportunities to learn about Interact, including presentations by the Healthcare Association of New Jersey, healthcare professionals throughout the state, professional organizations, including, as you said, the New Jersey American Assisted Living Nurses Association, as well as there has been documentation in many healthcare journals. The documentation clearly presented that the assisted living residents will benefit from the Interact tools.
Who would make that decision to implement Interact?
Well, the decision to implement Interact will be made by the clinical or the management team of any assisted living organization.
Do you think champions and co-champions would be effective in your setting?
Definitely. The nurse leaders in our organization are interactive, and they wanted to improve the resident outcomes based on resident choice and whether or not the resident could safely be cared for in the assisted living environment based on clinical assessment. We depend on our caregivers as crucial members of our team. We identify, train, and coach our caregivers to become lead aides in our organization. We look for those employees who are receptive to the change and that demonstrated leadership abilities that could present Interact in a positive way.
In your implementation of Interact, when the forms and the quality program is all set for assisted living, would it be by area or system-wide?
We would start with one individual community in which we piloted, and then once the programs for assisted living are fully developed, it would go organization-wide.
Which of the Interact tools would you use and why?
Well, the stop and watch, the F4, the capabilities list, and the root cause analysis. We certainly believe that the nurses will find it much easier to initiate dialogue regarding the end-of-life issues using the conversation starters, especially the CPR conversation.
Have you found the website, the Interact website, useful for resident education handouts or guidance for having the end-of-life conversations?
Yes, definitely. We've found the website very useful. There's plentiful information on the website that will definitely help us on the assisted living side to
going forward, would you consider using the Interact Quality Improvement Program tools to increase the awareness of advanced care planning?
Absolutely. I believe that the assisted living organizations will make end-of-life decisions easier for our residents and their families if they have the opportunity to express how they want to be cared for ahead of time.
And we know that the PULSE form is mandated by law in the state of New Jersey. Has your community incorporated that into their practice?
We've initiated a staff education process and hope to continue discussions with our physicians or nurse practitioners and plan to implement using PULSE once our education is completed.
Often assisted living communities follow the mantra, when in doubt, send them out. How do you see that as a challenge?
Well, our challenges include staff competency, the training and education so that our staff truly understands the value and benefits to our residents. Second would be the family education component and acceptance. By educating our families, they'll be more comfortable keeping their loved ones in assisted living.
At this time, are you measuring resident transfers and readmissions? Are you getting an idea of how many you do send out?
At the present time, we're not collecting data, but we are planning to implement a data collection process once all the tools are implemented.
I just want to add to that there is NCAL, the National Center for Assisted Living, has entered into a PFO with New Jersey Hospital Association, which allows assisted living across the nation to gather data, collected and have it analyzed with no liability. It will not be discoverable, and it will be information that will help them and the assisted living communities get to the reasons why admissions and readmissions occur.
You know, there's one other challenge that I see, which is the lack of reimbursement. When managed care for assisted living becomes effective January 1st of 2014, one way to get these services paid for is to negotiate with the insurance companies a payment that will allow the implementation of the interventions such as telemonitoring, intravenous antibiotics, and intravenous fluids for dehydration, amongst other things.
Have root cause analysis of readmissions been effective for identifying areas that may need reassessment? I know we did in assisted living a very cursory look at readmissions.
Correct.
How do you plan to continue with that?
Well, at this particular time, we've not conducted the root cause analysis of hospitalizations, but we're planning to meet with a group of health service directors in the near future. At that time, they'll be planning and developing the educational tools to implement them. We're also in the process of developing an electronic health record for our assisted living organization. We do expect that this will be able to aid us in our data collection in order to prevent medical issues such as delirium in our residents suspected of a urinary tract infection. We can then collect the urine, get the sample to help determine if an infection is present. Following through with that, we can send the urine for culture and sensitivity. However, the preliminary information can be communicated to the physician so that a timely decision is made to initiate treatment, which can result in avoiding the hospitalization and the resident experience of delirium.
Considering that the goal is to keep residents out of the hospital and improve communication between healthcare providers, what services would you include in the assisted living capabilities list?
In the assisted living setting, we have the capabilities of using laboratory services. An organization could negotiate a 4 to 6 hour turnaround on a stat lab work. Most assisted living organizations also have the opportunity to do radiological and Doppler studies, which are performed by the outside vendors, with the results directly reported to the physician.
How do you anticipate that using the Interact Quality program will increase resident satisfaction, resident outcomes, and quality of life?
Well, we definitely see that the Interact Quality program can increase our resident and family satisfaction by identifying the resident changes in a timely manner and decreasing the hospitalizations, preventing the loss of independence, and decreasing the costs associated with the hospitalization and the inpatient rehab services that may be needed.
Excellent. This is our contact information. Should you have any questions specific to assisted living, myself and Elaine would be happy if you would contact us. And now I'll turn the program over to Dinah.
Wonderful. Thank you, Loretta, and thank you, Elaine. Wonderful interview. Now we'd like to hopefully have another polling question. This time, hopefully, we'll have results. So if we could please bring up the polling question, that'd be wonderful. And the question is, what do you see as the biggest value in the Interact Quality Improvement Program? And you have 30 seconds to select any of the selections there. So it looks like we have our 30 seconds complete, and we'll hopefully see results in the next few seconds. This is like watching the Oscars. Who's going to win? Oh, how exciting. We have multiple bars. Well, It's the second option. They're focusing on continuous quality improvement. I think you're absolutely right, having heard that from, so with that, I will be turning it back over to Loretta, who will introduce our next speaker.
Good morning again. It's my pleasure to introduce you Karen Gentile, who is the Director of Nursing at Inglemoor Care Center, 120-bed subacute unit with 60 beds located in Livingston, New Jersey. And Karen's going to share with us the implementation of the quality program and what success she had. Good morning.
Hi, good morning. Thank you. I just wanted to share we are a 130-bed facility in Livingston, New Jersey, and we initiated Interact probably about 8 months ago, and we've struggled with it a little, but we've also had some great successes. Initially, next slide, please. The decision makers at our facility were in nursing administration, but it was supported by management. And what we were seeing is that patients were being discharged from the hospital earlier and earlier, and we noticed the need to strengthen our competencies of our nurses and to improve quality outcomes. We also were looking to be the leader in reducing readmissions from our long-term subacute facility back to the hospital. And next slide, please. As far as champions, the lead was our Director of Nursing and the nurse educator, but we also chose to utilize one nurse and one CNA from each of the 4 units. And our biggest thing is we had to work on changing the culture. It was important for us to choose people to be the champions that had strong leadership skills and also believed in the process and the need to change belief that it was easier to, when in doubt, to send them out, or sending a patient to the ER was easier. So we utilized those champions, and it really paid off. Next slide, please. As far as how we went about discovering Interact, about a year and a half, I'm sure a lot of you knew that Interact was a buzzword for everyone in the long-term care and subacute industry. And we initially did all of our own research online using the Interact website. And, we felt it was very important to utilize this information because at our facility, our readmission rate was approximately at 18% when we first started. And now, after 8 months, our readmission rate is down to about 10-11%. And utilizing this information, the whole goal of Interact is to improve care and reduce the frequency of those potentially avoidable transfers back to acute care. We also did some training sessions at the Healthcare Association of New Jersey, which were very beneficial in bringing the information back to our facility. Next slide, please. As far as implementation, we implemented it with all nurses on all 4 units. And initially, it was to emphasize that early identification through frequent admissions and readmissions, utilizing the Interact Care Path. And what we did is we utilized our nurse practitioner and our physicians to do education with the nurses and help them develop stronger assessment skills. We rolled out each care path separately after education was done, and the physicians and the nurse practitioners were very big on kind of helping the nurses to strengthen their core competencies in assessment in each of those areas. We first started with congestive heart failure care path, and then we rolled out the other ones after that. We also rolled out the importance of the communication, because I know Denise had mentioned it earlier. Some of the things that we found our facility was lacking is the ability to communicate with the physicians as to what we were noticing in an assessment of the patient, and that's where the SBAR became so crucial. Initially, our nurses didn't feel that the SBAR was cumbersome, and they looked at it as another, piece of paper to fill out. But through education and re-education, they noticed that it was helping to improve communication to the physicians and the need to properly communicate different things. After the initiation with the nurses, we did roll out the stop and watch with our aides, our dietary, and our housekeeping staff. The big emphasis here was, kind of looking to empower them, as they are often the first person to recognize or notice things that have changed in a patient, and empowering them to report those changes to the nurses. Next slide, please. The tools that we are utilizing from Interact are a lot of the communication tools that I just went over, the stop and watch. We struggle with the information. Another barrier that we had with the stop and watch initially was they were communicating it, but then the aides became discouraged a little bit because they didn't see that the nurses were responsive to the things that they were reporting. So that was, again, more education that we had to do with the nurses and how important it is to follow up on the information that is communicated. We also are utilizing the SBAR tool. We've been utilizing it for probably about 8 months, and it has definitely increased communication across the board. It also has increased nurses' credibility. A lot of times, our nurses were very quick to just state that, the patient doesn't look good. And now with that SBAR, they are communicating, everything that they're seeing with the physician. They also are communicating to an on-call physician who might not have received very good report from their fellow physician, and providing information, such as whether the patient is at do not resuscitate or has a dance directive. The use of the SBAR allows the nurse to capture and communicate that critical information. We also are utilizing the nursing home capability list. We are sharing them with all of our local hospitals as to what we are capable of and the services that we have to offer. We also send the nursing home capability list out with each transfer that goes back to the hospital, just to reinforce that, we want the patient back and this is what we're capable of doing. The other information tools we are utilizing is, just the website for Interact. It's been a wealth of information to help roll out the program. Next slide, please. As far as advanced care planning, we are utilizing the New Jersey Pulse. We do go over this with the resident and the responsible decision maker early, like within the first 48 hours of admission. We try to have the Pulse completed and signed on the chart. It really helps direct the care at times of changes in patient condition. We also revisit the Pulse and update it on a quarterly basis and with any significant change. Before noticing a change, we always go back to the Pulse and revisit it with, either the patient or their significant other to see if any of their wishes has changed. Next slide, please. As far as Englemore's barriers and successes, we've had many, and I would think that the biggest barrier that we had to overcome is change. Staff education is ongoing, and people are resistive initially to implementing something new. But again, seeing that the change and the results that we've seen from the changes have been good, it has been a continuous process. And, educating the nurses and helping them realize that they are capable of caring for more acute patient conditions. Also, the mindset of, the need to send the patient out is better. That it was a big barrier to overcome, and now nurses are empowered that, yes, we can handle these patients. We can look to handle the more acute patients. Those were the biggest barriers. As far as successes, I believe that our nurses are better trained. They're assessing patients more regularly. And they're empowered and have better assessment skills. Also, we have increased communication. Like I said, we're not only communicating to the physicians better, we're communicating to families the changes that we're seeing, and they're recognizing changes earlier and communicating those changes so that, different things are recognized earlier. We also have decreased our readmissions. Like I said, about 8 months ago when we initially started tracking, we were at 18% readmission rate back to the hospital. And now, right now in August, we're at, 10, 11%. And we've also had better patient outcomes. We're managing symptoms better. Next slide, please. As far as measurements, we are tracking all planned and unplanned admissions back to the hospital. We're continuing to see a decrease in the readmissions as well as improving patient outcomes. And with every readmission that goes back to the hospital, we are conducting root cause analysis to help, analyze as to what we could have done better or, what processes do we need to improve. We look to do this root cause analysis as soon as a readmission occurs so that it's fresh in everybody's eyes. And we also utilize this information from the root cause analysis in our quarterly QA meetings. It's very important that Interact be a key aspect of the QI program. And the things that we've found through our root cause analysis, sometimes an assessment was not as complete as it could have been, or that maybe a nurse should have assessed a patient earlier and missed, the guide that care paths indicate. Also, we've noticed in the root cause analysis that information could have been better communicated, whether it be to a physician or a covering physician. We've also noticed in our root cause analysis that covering physicians are not fully informed, and they might not be aware of what we're capable of at our facility, and they choose to inappropriately send a patient to an emergency room. And the one thing through this conducting these root cause analysis is we have been encouraging the nurses and empowering the nurses, if a physician says, to send a patient out, it's okay to say to a physician that, I think we're capable of handling the patient here. We can do this, this, and this for a patient. Next slide, please. As far as Anglemore's success stories, prior to implementing Interact, we would see a large amount of our cardiac patients, the ones with CHF, COPD, that would bounce back and forth between the hospital and our facility. And after implementing Interact and, educating and the continuation of ongoing education, we've seen that we are better capable of caring for our cardiac patients. We've seen a big reduction in those cardiac bounce-back patients. We've also, one of the biggest things is we've empowered our staff and with physician support to better assess and recognize the changes. And the physicians are recognizing this, and, they're encouraging the nurses. And utilizing the Interact Care Path and acute change in condition file cards, we've been able to identify and recognize changes in patients and respond accordingly, which have helped to significantly reduce the number of patients readmitted to the hospital. And lastly, on our customer satisfaction surveys, we have improved our patient satisfaction. We've been managing symptoms better, and our quality outcomes have been improved by implementing Interact. And that is it. If anybody has any questions for me, or please don't hesitate to contact me.
Thank you, Karen, for your excellent report. And I'll turn the meeting over now to Dinah.
Wonderful indeed. Yes, thank you. So at this time, we will begin the question and answer portion of the webinar. If you have any questions for a particular presenter, please note their name or the facility that they represent so that we can move along with the questions as they come in. Operator, if I could ask at this time that you could open up the lines and provide the instructions on how to do so, I'd appreciate that.
Ladies and gentlemen, at this time, if you would like to ask a question, please press the #1 key on your phone. Again, ladies and gentlemen, if you have any questions, comments, or concerns, please press the #1 key on your phone. Our first question is from Elaine with Bayonne Medical Center. Elaine, please go ahead.
Yes, hi. I was just wondering if you have any suggestions for physicians who are steering patients to facilities that are not partnered with the hospital. I mean, we have to be compliant with patient choice, but many times the patients are steered by their physician's choice, and physicians do not want to use our partnered post-acute facilities where we get better results. Do you have any suggestions for that? That's a frequent problem.
This is Teresa from Robert Wood, New Brunswick. You know, at this point in time, we do not have any mandatory ways of doing things. You know, ultimately, it should be a patient choice. Where we're moving forward is we have a memorandum of agreement. We are about to send out to the facilities to say that, you know, we actually do not give our patients a preferred list at this point. We are trying to get to that point. Regarding the physician, we actually contact physicians for patients who have frequent readmission. We do not have automatic alerts yet in our electronic medical records. A one-to-one approach has been what we're doing. Hanging out in our medical staff office is also another strategy that we do. And telling them, hey, your patient's back again. What is it that we can do? You know what the vision program is all about. I think initially the data is being gathered, and I believe that there will come a point where the report cards of those physicians will also be made public, at least starting in the hospital.
Okay, but you don't give the patient some sort of a choice list? I thought that's mandated to give patients a choice of provide post-acute facilities to choose from.
Yes, there is. There is a list that is given, and it actually has everybody in it. Where we're moving into, once we send out our memorandum of agreement, the memorandum of agreement will say, you know, this is what we hope to do. We are offering you an opportunity to partner with us. This is what we can do for you.
Okay, so that you don't include them on your list of choices. Patients can still go there, but they just won't be included on the list of choices if they don't agree to this memorandum of agreement.
Actually, no, this is what's going to happen.
Mm-hmm.
This is how we envision it. We will envision that we will approach the patient and they say that you have been recommended to go to a post-acute care facility. This is a list of all the facilities, you know, area. And this is the list of our preferred partners.
Okay.
They get to see those.
Okay. All right. Thank you.
Wonderful. Thank you. If I could take the first question in the chat box. This was, again, for our Robert Wood presenter, Teresa. The question is from Barbara Sangiuliano. Could you explain the bedside delivery as discussed in your slide on barriers under the Robert Wood Johnson Legal and Risk Management?
Right. At this point, in our emergency room, we have bedside delivery, meaning we have a Walgreens on site, and when the patient gets discharged from the emergency department, they can provide. It's still a patient option, but if the patient chooses to use Walgreens for that particular discharge, Walgreens will provide all the discharge medication. We are wanting to expand that program to our telemetry unit, just one telemetry to trial it. And the risk management part is where that comes in. There's a lot of legalities that go into it. Having said that, I can tell you that over 200 hospitals around the country have implemented it in their hospital system. So we are getting there. We will be implementing it this year. We know that.
Teresa, I have a question. This is Loretta. I have also heard that Walgreens does a medication reconciliation.
And that is the advantage. When a patient gets enrolled voluntarily in a bedside delivery, the pharmacist, the physicians will actually do medication reconciliation prior to discharge. They can even realign some of the medications so that refills can potentially be all occurring at the same time. The patient is now, we can give them all the prescriptions and they might not necessarily fill it or have no capability of collecting it from the pharmacy. So this is just a way to ensure that they're going home with at least a month's worth of medication.
And that the medications are accurate.
And that the medications are accurate. So we do both inpatient MedRec and home visit MedRec.
Wonderful. Thank you. Are there any other questions in the phone line for us?
Yes. We have another question from Megan with Ocean Medical Center Dialysis. Megan, please go ahead.
Hi. Thank you so much for your presentation. My question pertains to self-determination. Obviously, in dialysis, we have patients who are going to be destined to be on dialysis, and then other patients that, through their own choices of not following up with their diabetes, high blood pressure, they end up on dialysis. And I see, as a social worker, those same behaviors. And that causes them, for example, overdoing their fluid and ending up with CHF in the emergency room. How does all of this come into play with self-determination for patients, and when you can find that the root cause has to do with their behaviors and their choices not to follow through with treatment recommendations?
This is Loretta. I will address that. The whole Interact Quality Program is tied into person-centered care. If a resident is non-compliant with their treatment or their treatment options, it is very appropriate for the physician to sit with that resident and spell it out that because of this non-compliance, this is what's going to happen. And that's what a pulse form should be done by the physician or the nurse practitioner. That will help guide you as a dialysis center what it is that this resident wants done or what is trying to be accomplished. Because there is going to have to be, according to the Affordable Care Act, there's going to have to be some accountability of this, because that resident will wind up in a hospital because of their behavior. So when you have somebody who triggers that, my first response would be to go to the physician, either the nephrologist or the primary care doctor, and have that conversation that this is what the resident wants done, regardless of what his behavior is, and then you know what you have to do. Yeah.
Loretta, this is Karen. I also wanted to comment on this. Right now, in the local hospitals around Livingston, they also are identifying those more frequent non-compliant patients that have an increased readmission rate to the hospital. And one of the things that area hospitals here are doing, they are sending a nurse practitioner into the home to follow up with these patients on an ongoing basis. Because some of these patients have ended up in our subacute facility, are non-compliant here, and continue that non-compliance at home. So that is one of the things that they are looking to do to help educate and, like you were saying, to
look to have kind of a candid conversation with them and complete a pulse that, identifies, what it is, their wishes are. So that is one thing that they are doing here, too.
This is Megan again. I think, I'm not sure who, I think it was Loretta that said the accountability is on the facilities, the clinicians, the doctors, but not on the patient. And I guess that's where I get stuck, and it's just, it is what it is, and you have to accept that. But there really is, when it comes to the Affordable Care Act and the reimbursement, it's not going to affect the patient's pocketbook. It's going to affect ours, and that's just like a frustrating thing for PMI staff.
Right. You're absolutely right. But this is the first step in the attempt to put it on the resident or the patient, the accountability for if you insist on doing this, behavior, this is what's going to happen. The other thing, and I'm not going to say that I know this for sure, but I have read in the Accountable Care Act that such behavior must be, resident patient must be seen by a psychologist to determine what the root cause analysis of the behavior is. So that may be another option for your social worker, maybe to recommend to the doctor that a psych consult be ordered to see what the resident or what the patient's underlying cause of this behavior is.
This is Teresa from Robertwood. When we first instituted our transitional care program, we excluded dialysis patients. Because
I can't imagine why, Teresa.
only because it's a usual exclusion factor in the transition model. But it didn't take us long to realize they were rebounding just as bad as the others. Therefore, we changed our workflow, and we now actually enroll them. And by doing so, we're doing the first part of re-educating the patient, visiting them at home and finding out. The other thing is there are dialysis programs now that have started to look into transitional care. They have even instituted, some of them have one I know have even employed a nurse practitioner. And they do their own transition. There's a demonstration program that is out there right now. People have applied, facilities have applied. So that the dialysis times will be used as re-education time. Those 3 hours, 4 hours that they spend, there's plenty of time to do med-rec. They tend to do med-rec for every dialysis. And that's probably what they need. Maybe for some, you'll have success by reinforcing the education. So one encounter usually with these patients is not enough. And so capturing them when they're really captive can go nowhere, maybe. So it's happening.
Thank you, everybody. There's another question here in the chat box. It's from Lynn St. Hilaire. I do apologize if I mispronounced her name. The question is, for facilities working with the emergency rooms, has this partnership impacted readmission patterns, or would you attribute the result to internal changes only?
Hi, this is Karen. I can comment on this question. As far as we've definitely increased our communication with the emergency room and with area hospitals, and one of the things that I can say is the local hospitals in this area are definitely looking at subacute and long-term care facilities readmission rates. As far as the changes that we made, I think that the results are proof as to, processes that we put in place that have helped our nurses, care for these patients, and, the hospitals have verbalized to us that they are pleased with us implementing Interact and are pleased with the results that, we've been able to show.
I'll make a quick comment. It's Teresa. I think the meetings with the post-acute care have heightened their awareness that the hospitals are looking. They actually had a follow-up meeting March of 2013 after that main meeting where we engaged the help of HQSI to actually provide we identified aggregate data where the post-acute care facilities were able to compare themselves with the area facilities. And I think that was a revelation. They also received their own data. And I think it starts there. The change will start there. At Robert Wood, we intend to have a mandatory in our electronic medical record identification of the specific facility. Because right now, the documentation of sometimes just says that the patient is a transfer from a nursing home. We intend to be more specific with that, and that's an information we also intend to share. So we've been very clear about saying we're tracking you track us too, and we'll share the information with you.
Just to add that there is data available monthly to show the best performers in the area as far as the reduction of admissions and the worst ones. So you really want to stay out of that bottom number, and when you are a good performer and you are doing your job, that is a powerful document that you present to the hospital and the emergency department. And I'll just add that it's really important that that emergency department knows what you're capable of taking care of. So if they do an evaluation and it's something that you can do back at your subacute, you don't need to have that resident admitted.
I will also add, it's Teresa again, that most emergency rooms probably at this point have dedicated case managers. And they would be a very good liaison, targeted person in the emergency that the post-acute care can probably direct their interact, for program initiatives that make them known to the case managers. At Robert Wood, we have a rolling 100 utilizer. We know our top 100 utilizers in the emergency room, and the case managers actually work on that rolling top 100. And we get an alert if any of those people in the top 100 hit the emergency room immediately as they register.
Thank you, everybody. And I think just hearing all our different presenters talk about the nursing capabilities list, and again, reiterated here from our presenters, it is a very important document. So it's a good place to start if you are a facility to fill that out and get in touch with the emergency rooms. I saw some postings in the chat about the slides. They will be made available on our website. And once they're posted, we will send everybody an email there. I'd like to go back to the phone line to see if we have any other questions there.
Yes, we have another question from Deborah with Chelsea at Bald Eagle. Deborah, please go ahead.
That's what I'm saying. I just saw it this morning. And now he's over here, and I just happened to notice it. I was walking past.
There are no further questions in queue.
Okay, thank you. I don't see any other chat box questions at this time either. So with that, I think I'd like to thank all of our presenters, Erin, Denise, and Donna, wonderful job, and here in the room, Teresa and Elaine, thank you very much, and of course, our super facilitators, Loretta and Janet. Thank you, everybody. Again, the slides will be made available, and we will email. I do apologize for that disturbance on the phone. Otherwise, thank you very much, and I wish everybody a beautiful sunny day here in August. Enjoy the 12 minutes until 11:30. So thank you very much.
Thank you, ladies and gentlemen. This concludes your call.